So for the sake of time, we'll start with this session. This session will be some kind of unusual case presentations and discussions. We'll start first with Dr. Walid Shakir, our prominent cardiothoracic surgeon from Mediclinic Airport Road. He'll be talking about a malignant coronary malformation as a cause of sudden cardiac death in a young age. Dr. Shakir, the floor is yours.
Thank you, Dr. Eli. Good morning, friends and colleagues. As a cardiac surgeon, it's always a privilege to be with this elite group of cardiologists. And to change the mood a little bit from the acquired heart disease, I will just present now a rare case of congenital coronary malformation we operated recently in Mediclinic Hospital, Airport Road. I think I need some help from the audiovisual here. The slides are not moving. Okay. So we know that the sudden cardiac death is the main cause of the sudden cardiac death is the coronary pathology, mainly the acquired pathology. The other causes include the cardiomyopathies and the inherited arrhythmia syndrome like the Brugada syndrome, the valvular heart disease, and other. And we know that the second most common cause of sudden cardiac death in young age is a congenital coronary malformation. To prevent this case, a lady, 52-year-old, she's a physiotherapist, so she's working in the medical field, and she had a typical anginal pain on effort during her work and her physio exercise job. The TMT showed positive ischemia, and she visited our heart team, and I want to appraise the heart team and Dr. Andron, I think he's not here, for his good diagnosis for this case. And so this is how we see her thallium. She went for perfusion scan, and the perfusion scan came like positive for basal septal hypoperfusion during stress. She proceeded for coronary angiogram, and this is how we see in the coronary angiogram. So we can see the right coronary artery is arising just next to the left coronary ostium. So we had a first diagnosis of abnormal origin of the right coronary artery from the opposite coronary sinus. This was confirmed by IVUS, and we know that we have also proximal narrowing and proximal stenosis and the slit-like orifice of the right coronary. The CT angiocoronary confirmed the diagnosis, and as we can see here, a very clear origin of the right coronary from the left coronary ostium with a very narrow compressed interarterial course. So you can see here this part between the pulmonary artery and between the aorta, and this part of the right coronary is compressed during exercise because of the expansion of both major vessels. Here, this is the origin of the left coronary ostium, and both are coming on that same orifice almost. This is how we see the anatomy in the surgical view. So as you see, this is the aorta, this is the pulmonary, this is a left coronary ostium, and we can see the right coronary artery arising from the abnormal left coronary ostium instead of arising from the usual place. The patient went for surgical correction, which is a very rare case. I can tell you that I operated maybe 5 to 6 cases during all my 30 years surgical career. So as we see here, this is a reconstructive CT angiocoronary, and we can see here the interarterial part. the origin of the right coronary near to the left coronary ostium, and this is after the correction. And we did a translocation of the right coronary artery to the normal coronary sinus. I will speak about the surgical technique by the end of the presentation. So this is by the CT coronary angio. So as we see, we eliminated this interarterial part, which is a cause of the exertional angina, and we translocated to the normal position in the right coronary sinus. So we know all that the coronary anatomy has always many variants. Some of them are benign variant, which is not producing any clinical symptoms, maybe giving some challenges for the interventional cardiologist, but otherwise with no clinical manifestation. But we know also that some of them are very malignant coronary anatomy. And in one of the largest autopsy studies conducted to date, they found that the anomalous coronary anatomy is the second most common cause of sudden cardiac death in young age. And the challenge in this case is that most of these cases are asymptomatic. We thought that the percent of the coronary anomaly in general is less than 1%, but in fact, with widespread use of the CT coronary angio, we know now it is more than this, and in some studies even it can reach up to 8% as an incidence. This is how we classify the coronary anomaly. So we have anomalies from origin, from course, and from termination. The anomaly from origin, we know that sometimes the coronary artery will arise from the pulmonary. Right we call arcaba, left we call alcaba. Sometimes it is arising from the aortic origin, but from the opposite sinus. The anomaly of the cause includes a bridging by muscle bridge in HCM or congenital aneurysm. The anomaly of termination includes the coronary fistula and the coronary atresia. This is some example. This graph is showing some examples of the anomalies. So the first one will show the abnormal origin from the pulmonary. This is the abnormal origin of the left coronary from the opposite sinus of the aorta. This is the coronary atresia. This is how we see the bridging of the coronary. This is the aneurysm, and this is the coronary fistula. By the way, the coronary fistula are common enough, and we see it, but not all of them require surgical intervention. It depends on the degree of shunting and the steal phenomena between the coronary and the cavity. Usually they drain into the right cavity of the heart, to the pulmonary artery or to the right atrium. I'll start with the pulmonary origin. So the pulmonary origin, we know that they are a very serious condition, and always they present in the infant stage. The right coronary origin, which is the arcaba, may have a delayed presentation if we have a strong collateral system from the left side covering the right artery territory. The left coronary artery is more serious condition. Usually they don't survive to the adulthood, but some of them, as in some studies, they can survive, and most of them will be symptomatic, will have ventricular arrhythmias or even sudden cardiac death. The coronary anomaly from the aortic origin is the most common of this category, and they originate from the opposite sinus, as we saw in our case, and they are the most common cause of of deaths, 17% in American athlete in one of the largest study. It is the most frequently involved in the presence of high-risk feature like slit-like ostium, acute takeoff, and interarterial course. This will increase the incidence of sudden cardiac death. So this is a problem here. This is here the right coronary from the left, and this is the left coronary from the right. And this segment is the real problem, the compressed interarterial segment during exercise, and this is the cause of ischemia, exertional angina, and the sudden cardiac death. What we should do for this patient, or what we should do for people who want to go for competitive sport and exercise. Should we restrict the exercise? Of course, this patient should be restricted from exercise. And we know that the sudden cardiac death occur in this patient during exercise. Symptoms such as exertional dyspnea and chest discomfort should be alarming for all practitioners to detect this patient. And it has been shown that the coronary artery anomaly related sudden cardiac death occur in 50% of cases previously asymptomatic. So the eligibility for exercise should be really detected in these cases. And we know that all cardiologists, they have the 14 element as per the AHA guidelines, just to make sure that we are not missing a young adult with congenital coronary anomalies or other anomaly can produce sudden cardiac death. And the 14 element including the family history, personal history, and the physical examination. In a major study in British Columbia, Canada, they studied maybe around 800 young adults going for competitive sport. And they passed by the first stage, the initial screening by the 14 element. And some of them required to go for a second stage using a TMT test. And the other remaining part required to go to the stage 3 by further investigation by echo, coronary angiography, or even CT angio, as a surprise that 11.4% of this young adult, so that's mean more than 80 from 800, they discover that they have significant cardiovascular disease and malformation contraindicating the surgical exercise. So the take-home message from this study is that if you have a child or a neighbor or a friend, young adult who want to go for really aggressive competitive exercise, please let him go for screening. The investigation for this kind of cases is classified into anatomical and functional. Anatomical, of course, we have to know the anatomy of the malformation, including the echocardiography, but I think you know better than me that the echocardiography may miss such kind of coronary malformation. The coronary angio will be more a conclusive test, and the CT angio coronary now is giving us better result. The functional test is also very important because we have to know if this patient having ischemia or not by TMT, by stress echo, and by nuclear imaging. The surgery in the guidelines, this is for the coronary anomaly from the pulmonary. Most of the cases are indicated for surgery, as you see, class of evidence 1 and class 2A. For the left coronary, originating from the opposite sinus, it's also, from the aorta, it is also indicated surgical intervention and correction in most of the cases. And only the right coronary anomaly from the left sinus, if no symptoms, no ischemic changes, and no ventricular arrhythmia, we can have the choice between the surgical correction and the continued observation as a 2B classification. So we can see that the surgical correction is a golden key in these cases. This is some of the surgical techniques. So this is how we see the interarterial segment. This interarterial segment can be intramural, as we see it in this graph, or extramural. And when it is intramural, we have an unroofing technique for the interarterial segment. So we just unroof this canal and we shift the ostium from the abnormal malignant position to the normal position. And we have to be careful because this unroofing can produce some prolapse of the aortic valve commissure and produce some aortic regurgitation after surgery. The most common technique is by translocation, as we did for our case. So what we did is, this was the anatomy of our case, a right coronary artery arising from the left coronary sinus. So we take a button, including the ostium, and we translocate this to the normal position. In fact, in this case, we didn't use the button because the orifice was like a slit shape or like a fish mouth shape, and it was very narrow, and the proximal part, as we saw it, was also very narrow. So we translocated the right coronary after splitting the right coronary maybe few millimeter above the aortic origin and translocated to the opposite coronary sinus. Thank you very much for your interest.
Thank you, Dr. Shakir. This was a very interesting case and review of the anomalous coronaries. I will start with a question. The challenge is in the asymptomatic patients, the young patients and the ones we just diagnosed routinely by an abnormal stress test coming from for medical insurance, and now with the use of CT scans, we are definitely not missing those cases. So this is where the challenge is, especially in the right coronary arteries, and what to do with those patients. And as you mentioned in the guidelines, so for the left side, even if they are not symptomatic, definitely the management will be more aggressive. But the more common are the right coronaries, and we're facing many of those young patients. And the challenge is what to tell them, how to control their lifestyle, and whether to go to surgery or put on medical treatment. You did not mention lots of things about medical treatment of those patients, especially the use of rate control, beta blockers, and definitely the lifestyle control. So in your opinion, we'll start with the symptomatic cases, definitely. So we have to do something about, and we have to diagnose them very well, especially by nuclear or MRI, or sometimes with the cardiac catheterization and like dobutamine cath. I wish Dr. Andron was here. He had lots of experience in dobutamine cath, maybe. So for this case, you relied on symptoms, anatomy, and what about
ischemia?
Ischemia, like what kind of functional studies? You did
function was okay, so the ejection fraction was.
No, I mean like wall motion abnormalities, or
there was no wall motion abnormality by echo, but she has a perfusion defect by Salium scan. She has
so you used nuclear.
Yes, she had a basal septal perfusion defect. She had a positive TMT test for ischemia, and she never got any high troponin, but she's symptomatic with exertional angina, recurrent exertional angina. She was a physiotherapist, so once she started working, so she started to have the epigastric pain. So all the conditions were in favor to go for surgery. And as per your question, the asymptomatic patient is a challenge, especially when we deal with a young age adults. But as you saw with our guidelines in the American Heart Association, these patients are exposed to a high risk of sudden cardiac death. And it is the second most common cause in sudden cardiac death in athletes. And we saw a lot of football players and other sports, young people having arrests in the playing floor. So I believe that the golden key for the management of this patient is the surgical. Although the medical treatment can improve the symptoms a little bit, but it will never prevent the disease because we have a congenital anomaly. So I believe that the surgical correction is a golden key of management, supported by the medical treatment till we reach the point of surgery. The real challenge, as we said, is to convince an asymptomatic young adult athlete to go for a surgical correction. But I did some of these cases, yani I did even trainer in the military, and they had bridging of the LLD with very low FFR and indicated with severe symptoms, and they benefit from this kind of surgery, whether unroofing of the bridge or correction of these coronary anomalies.
Any questions from the audience, please? Adi.
Thank you very much, Dr. Walid, for the comprehensive lecture. It's a bit of a query, not a question, because I had a patient like 2 years ago, a young Indian lady, who had very non-specific symptoms like chest pain, but not really on effort, some dyspnea, and then coincidentally by the echo I found that she had a persistent left superior vena cava, along with a huge coronary sinus. After I injected the bubble study, we confirmed all the things. Then I referred her for CT angio, treadmill, and all the things. And on CT angio, we found that she had a malignant course of RCA, anomalous RCA with a malignant course and interarterial. So it's between the pulmonary trunk and the aorta. With a slit-like opening, like you said, interarterial course, all the signs of malignant course. However, it was a very rudimentary RCA. It was a very small branch. So we suspected whether these symptoms are really specific, is it related to ischemia or not. We did functional tests, like Dr. Ali said, and it was a perfusion scan. It was negative, to be honest. We did a coronary angiogram as well. So those patients, if they have a non-dominant RCA or a rudimentary RCA, would you go for surgery if they still have these non-specific symptoms, or you will just avoid surgery?
Thank you, Dr. Fadi, for the question. For non-dominant RCA is no question of surgery, of course, because you don't depend on the non-dominant RCA. But I'm speaking about like this case. We saw the angiogram. It is a very big RCA,
large one,
and dominant and giving the PDA and PLA branch. And we believed as a heart team that this is the cause of her symptoms and her exertional angina. And by correcting this course and by removing this interarterial course, we got a very good result, and the patient now back to work, and she doesn't have her pain anymore. So of course we need to have evidence that these symptoms are related to a relevant right coronary artery, dominant and responsible of the ischemia symptoms.
Thank you very much.
Thank you, Dr. Walid, for your lecture. I faced one case a little bit like that, but it's very rare congenital anomaly, and I need your great opinion about this. He's like 45 years old, gentleman, and he's experiencing some uneasiness only with severe exertion. So we did the exercise test. He reached about 13 METs on the peak. He has some uneasiness, nothing more than that, and no ECG changes. But I feel uncomfortable, and sometimes you have to go after your feelings and heart. So we did CT angio. We found that he has single coronary. It's the RCA, and after few millimeters, the left mean is coming, and the LAD is going to the apex, then the LCX is going back. So, and there is...
it is a common origin of the right and the left, right?
It's it is one origin from the right, and now, I don't know, the right is acting as left mean, the proximal right. Okay? And after that, it is split into one vessel. One is acting like the LAD going to the apex, and one is going down as LCX.
This is quite rare.
And by the end, there is only moderate disease in the LAD distal. So they just do some ballooning of this, and we referred him for cardiac surgeons, and they were hesitant to do anything for him. Imagine if this patient had proximal RCE lesion, it's like he had left mean equivalent. So what to do in such like case? What's your opinion?
But we have to watch your patient. I mean, regular follow-up and see if he has any symptomatology, and then if he has any perfusion defect, and then you can start deciding if you need any kind
No
of
perfusion defect.
correction of this anatomy.
Thank you.
For the sake of time, we'll proceed for the next presentation by Dr. Tamer Badawi. He's a consultant cardiologist at Mediclinic Noor Hospital, Khalifa Street. He'll present a case about elevated troponin in children. Dr. Tamer.
Good morning, everybody. So this is a very interesting case which we had last year. So this is actually a patient. I got a call from the ER at night that we had this 16-year-old boy coming to the emergency complaining from chest pain after he had a football match. He doesn't have any risk factors, of course, and his vitals and examinations were normal, nothing unusual. And this is his ECG. So ECG was completely normal, cannot find any changes. And they did, usually in the ER, they're doing routine labs for anybody coming with chest pain. They will do the kidney, liver, and of course, troponin. So they called me and said, so this patient has high troponin of 77 and coming with chest pain, all his labs are normal, doesn't have anything. So what should we do? So when you come to think of it, 16-year-olds with high troponin, you think of pericarditis, myocarditis. So anyways, I told them, let's admit the patient. We'll do for him the routine investigations, echo, and so on, and then we'll see how it goes. So the patient was admitted, and again, we said the differential diagnosis would be pericarditis, myocarditis, acute coronary syndrome would be out of the way, but it was in the differential diagnosis. So we did an echo for him. So echo was normal, ejection fraction 70%, valves was normal, no issues, no pericardial effusion, nothing. You can see from the echo images here. So the next day when we saw the patient, he was completely fine, no specific chest pain, he doesn't have any symptoms, everything was okay. We repeated for him a lipid profile which was within the normal limits. However, his troponin on the next day was 257, which is still okay. It might be myocarditis, pericarditis, maybe it's a little bit early. So we did the ECG again, no significant changes. Patient was stable, no issues, and we were planning just in case if we're gonna go for a CT coronary, just to rule it out. So we put him on bisoprolol 2.5, and then the next day we'd go for a CT coronary. So next day we sent him for a CT coronary. So CT coronary, he did the calcium score first, and it was 0, of course. And when we proceeded for the angiogram, the patient became a little bit tense, and his heart rate started to increase. So we aborted the procedure. Now the problem with this patient is he has a relative who is a physician, his uncle, and he was getting involved. He's not a cardiologist, but he was getting involved in the case. So when we first admitted the case, he was saying, are we gonna do an angio for him? I told him, no, we're not gonna do any angio for a 16-year-old at first. We have to find out what the diagnosis, then we'll do it later. Most probably it's gonna be like pericarditis or myocarditis. So again, we're repeated the troponin the next day when we were going to prepare the patient for another set of CT coronary, and it came 1,000. So this number actually does not go with pericarditis or myocarditis. The number is very, very high. So we decided, after taking from my colleagues in the department, this patient will need an angiogram. We have to find out if something we're missing or not. And again, the family interfered, his relative interfered and said, no, this is, we got multiple opinions from doctors and friends, and they said, this is myocarditis, we should proceed with an MRI, a cardiac MRI. So we had an argument. I convinced the family that we're not going to lose anything if you do an angiogram. So if it becomes normal, then we clear this out. And usually angiograms like radiological procedure. So they agreed finally, and we went for the angiogram. You see the right coronary artery was normal. And this is the left side, and you can see that there is a filling defect here in the proximal LED. You can see there is something in the proximal LED. You can see it also here, there's a filling defect. again, you can see there is something here in the proximal LED. So it looks like it's a thrombus, and the decision was that time to start the patient on aspirin, ticagrelor, and he was started on tirofiban infusion for 48 hours. And then we're going to repeat again the angiogram after 48 hours, and we're going to do an IVUS just to make sure the endothelium is healthy or not. So this is after 48 hours. You can see that there is still, you can see it maybe in the next images, thrombus is reduced in size significantly, but it's not completely dissolved. I think here it might be, yeah, you can see it here. So it's still there, significantly less than the previous one, 48 hours prior. And this is the IVUS image. So IVUS image showed that it is actually a healthy endothelium. So the patient does not have any atherosclerotic cardiovascular disease. So actually, the patient was discharged on aspirin. He was fine, discharged him on aspirin and ticagrelor, and we repeated troponin. Again, he came for follow-up after 10 days. It was back to normal again. However, the patient has some abnormality, so we referred him. We suspected that he might have hypercoagulative state, so we referred him to the hematologist. So hematologist did for him, this is the lupus anticoagulant, did for him the full screen for hypercoagulative state, and the lupus anticoagulant came high in 2 settings. So he did it first, and then he repeated again after a few months, and again it came back high, and it was confirmed that this patient has the lupus anticoagulant, which is a part of the antiphospholipid antibody syndrome, and he started him on long-term anticoagulation. So he stopped the aspirin and the ticagrelor, and the patient was put on warfarin with a target INR of 2.5 to 3. It's been a year. The patient has been followed up regularly with us and with the hematologist, and he's been doing fine ever since. No issues whatsoever. And thank you.
Thank you, Dr. Iman. Dr. Iman has a question.
Thank you, Dr. Tamer, for your elegant presentation. And I have 2 questions. First of all, when you went on the first time and you saw a thrombus, I mean, why the age got into your decision? I mean, if this was a 35 years old, a 40 years old patient, you would have went for stenting, right?
Yeah.
Why did you take the decision to take him to the ICU, start him on tirofiban and so on?
This is the
Why?
reason, because
I mean, the guidelines do not mention anything about the age.
So this was a debate with the interventionist cardiologist, because we don't know whether this is a healthy, so you put a stent in a 16-year-old, and if it turns out it's a healthy endothelium, he'll have to be on antiplatelets for the rest of his life. So that was the issue, whether this is actually on top of a healthy endothelium or this is on top of after there is a plaque. And that's why we had to revert to IVUS after 48 hours, just to be sure.
And the other question is regarding the antiphospholipid syndrome. You mentioned that once he was diagnosed with antiphospholipid syndrome, you put a stent for him, right?
No, I didn't
You
put
no
stent.
stent,
No,
just
stent.
so once he was diagnosed, he was put on warfarin. Was it your decision or the rheumatologist?
This is the hematologist decision.
Hematologist,
and he did it twice to confirm.
So there is no role for NOAC here. I mean, rivaroxaban, edoxaban. I mean, warfarin is a big problem with this INR checking every month for a 16 years old. That's why I'm asking.
I think it depends on which type of hypercoagulative state that he has, because I think some do not respond well to the direct oral anticoagulants. So this was the decision by the hematologist to put him on warfarin.
And you wouldn't like to follow him up, I mean, by CT coronary, because I mean, there is a lesion there, and you did not put a stent. You only used the balloon, right?
No balloon, nothing.
No balloon.
Only tirofiban. Because there is no, with the IVUS, the endothelium is healthy. So if you put a balloon for him with a stent, you're putting something on a healthy endothelium. So that's the problem. He's actually following up. He doesn't have any symptoms. He's been doing troponin because his parents are worried. So whenever he comes for his visit, they ask for troponin, since this was like the diagnosing factor, and it came back normal. So he's doing fine, no symptoms.
And he's exercising. I mean, there is no contraindication
doing his
to
regular
exercise.
activities.
Thank you.
Dr. Rami has a comment, please. No, Dr. Bashar, okay.
I'm not a hematologist by any means, but I just wanted to circle back on Dr. Iman's comment about the appropriate anticoagulant. So with lupus, anticoagulant in patients with antiphospholipid with thrombosis, the gold standard is warfarin. DOACs are still not proven and actually not recommended if there's active thrombosis in these patients, which is unfortunate, but
Dr. Tamer, it should be a great heart team. I mean, just to hold the hand of the interventional cardiologist to do anything. I don't know if any of the Dr. Jerome is here. So it should be a very strong heart team to get this decision and to hold your hand from even suction of this kind of thrombus inside the LAD and doing even the balloon. And I think you went to the right way. Sometimes it is very difficult to hold yourself to do something aggressive, and congratulations.
Thank you. Thank you.
It's a very interesting case, thank you.
Thank
So
you.
we'll go again to Dr. Shakir with interesting surgical challenges with some case discussions. Please, Dr. Shakir.
So thanks again. During the next few minutes, I will just show some interesting surgical challenges and some of your referrals. I would like to thank you for all your surgical referral from all over UAE. Can we start the presentation, please? Okay, thank you very much. So I will present the first case. So a male patient, 67-year-old, he came to our heart team. He's coming from Dubai, and he came to our heart team with an acute on top of chronic heart failure, bilateral lower limb edema and right pleural effusion, disturbed liver function and congested liver. He was on anti-failure OMT, and the echo evaluation showed the following. Next slide, please. So his echo showed, next slide please, his echo showed severe degenerative calcific aortic stenosis with, as I remember, aortic valve area of 0.6 and with very high gradient mean and peak on rest and on exercise. He had also reduced LV function. I think his LV pressure was okay, so this is how we see his aortic valve, and his ejection fraction was reduced down to 40%. He had also pulmonary hypertension. Maybe the pulmonary pressure was estimated around 70. And with this, he had this moderate tricuspid regurgitation. So the patient has an end-stage aortic valve disease, aortic stenosis, with reduced LV function and pulmonary hypertension and secondary tricuspid regurgitation. So discussion within the heart team was between should we do a TAVR for him or we go for a surgical correction for the aortic valve. So what do you think? I need the opinion from the audience for this case. So aortic stenosis, calcific, low ejection fraction, 40%, heart failure, OMT, pulmonary hypertension, 70, and tricuspid regurgitation. What do you think, guys, as a heart team?
Mic to Dr. Iman. Somebody gives them the mic.
Mic for Dr. Iman, please. 67.
Thank you, Dr. Walid, for discussing the case.
Sorry, I will add an information. He was a football player.
Oh.
So he was a professional football player in Gaza team, by the way. And he was active till he developed the chronic heart failure.
I believe in this situation, in view of this echo and severe tricuspid regurgitation and the friable condition of the patient having heart failure, we could go for a bridging procedure by doing aortic dilatation, bridging until he stabilizes his condition, and then he can go for definitive surgery. Because taking him to surgery in such a heart failure condition might be at a high risk procedure for him.
Okay, so optimization first by trying to optimize him before going for the surgery. But you agree that the surgery will be the best option for him?
What's the condition of his coronaries, doctor? What's the condition of his coronaries?
Coronaries are normal. I think we have the coronary just. This is the answer of your question, Dr. Eli. So these are his coronaries. So it looks normal. Diffuse disease, but with no definite stenosis.
I think there is a main indication here for surgery because of the severe aortic valve disease. See, regarding, I think you've mentioned also that for the heart failure thing, this is also an indication for surgery if the patient is heart failure. We're not saying that he's an end-stage heart failure. His ejection fraction is around 40, 45, estimated by both eyeball, and I'm sure if we did GLS or global liquidus strain, we'll find it around the same level. He's compensated, but the thing that you cannot wait for much longer time for these patients. So I think the surgery will be mandatory.
So question, surgery or TAVI?
How old is he again, Dr. Walid?
67.
67.
Active person or previously active
So
person.
that means frailty score is low. So if you calculate the Euro score for the surgery, so that means the patient can go for surgery.
Okay.
He's not a high risk. He's not a very high risk, I mean.
Okay, so I think there is an agreement that surgery should be done, but after optimization by medical treatment, just to control his heart failure, to optimize his condition. And this is what we did for him. So we did for him aortic valve replacement. We used a bioprosthetic valve size 23, and we did also a tricuspid repair for his valve, and this is the result. So we have a great improvement of his ejection fraction. This is 2 months after we can see the difference in the ejection fraction, and the gradient was really reduced down to 30 and 17, and his tricuspid regurgitation almost disappeared. And the pulmonary pressure went down maybe to normal values. The second case is a 41-year-old male presented also with dyspnea on exertion, and he was also a basketball player, and he stopped playing once the symptoms started to increase. He had mitral valve prolapse with severe mitral regurgitation and chordal elongation and LA dilatation. I consider always the mitral repair as a challenging surgery, not because the surgery is risky. It is the lowest risk in heart surgery, by the way. We have a mortality rate in the mitral repair around 0.5%. But it is challenging because every surgery is a new surgery. You have to tailor your valve according to the anatomy of your valve. And none of the patients are identical. all the patients are different when we see the mitral valve and how to plan for your repair. So planning of the repair is very important to get the best result. That's why it is always challenging for the cardiac surgeons. So this is how we see his echo. So what do you think about this mitral anatomy? Any suggestion about the mechanism of
Yeah, there is a posterior leaflet significant prolapse, and I think there's a flail also with a chordal rupture.
Yes, absolutely. So it is mainly a P2, P3 prolapse, as you see, and we have an important gap because of the prolapse, and there is a huge elongation of the chordae of the P2 and the P3, creating a huge regurgitation. I want to run also the lower. This is a problem when you have many echoes. So the regurg was a very significant regurg, eccentric jet, and it is producing severe symptoms. So we planned for the repair. So the repair technique was by putting an annuloplasty ring size 30, and we did a new chordae implantation to the P2. And this is how we see the repair. So you can here see you see the shining white line here is a new chordae. Dr. Fadi, you can see it.
Yeah.
You can see it here. And we put the ring size 30, so this is really reduced ring size. And the chordae, the new chordae, just hold the posterior leaflet from further prolapse, and this stopped the whole regurg process, and no more mitral leak. And we can appreciate the reduced size of the LA also. So this is the same here. We can see the chordae. This is a new implanted chordae, which prevents the P2 prolapse and no more leak in this valve. The third case is a 63-year-old male. He was coming also from Dubai. He had previous mitral valve repair in another facility and cryo-maze ablation 5 years before his surgery. And this was complicated by residual severe mitral regurgitation, complete heart block, and he had a cardiac pacemaker. He presented with congestive heart failure. He was on OMT. He had a secondary pulmonary hypertension. He was on diuretics and Entresto, Xarelto for a paroxysmal atrial fibrillation. His echo and transesophageal echo showed residual severe mitral regurgitation post repair. So this is how the transthoracic echo was showing. And this is how we see his mitral valves. There is a gap, clear gap between very restricted and unmobile posterior leaflet, and this creates a significant regurg. I don't know why I cannot run the. Can you run from your side, please, the second echo? Audio visual. Can you run the second echo, please? The echo. Yes. Can you run this, please? Yes. Thank you. So this is how by a TE we see his regurgitation. So it is a significant kind of MR. This is his coronary angio. So he had normal coronaries. Can you run also the second echo, please? Okay. So the decision was to take him for a redo surgery, and to we discussed in our team, should we do a re-repair of the mitral valve, and we found that with this restricted posterior leaflet unmobile, it will not be possible to do. And efficient mitral repair, and we choose to replace the mitral valve with a biological valve and to repair the tricuspid valve, because he had also, we didn't see it in the second echo, he had also a tricuspid regurgitation. So we use the biological valve also, size 27, according to his age, he's 63, and this was the result after the surgery. Can we run the second echo, please? Thank you very much for your attention.
Okay, thank you, Dr. Shakir. The floor for questions. Dr. Iman. Since Fadi, the mic is with you, start. Yeah.
It's okay. Yeah. Thank you, Dr. Walid. So I just need to ask about the third case, the last case. What was the reason of the failed repair in the first instance? Was it a vegetative state, like was he had an endocarditis? Did he have an endocarditis, or was the valve itself, I mean the repair itself, was there was a structural damage to the annuloplasty ring, for example?
We don't know exactly what was the cause of his residual mitral regurgitation. He didn't have any history of infective endocarditis, even no evidence of subacute endocarditis, but he started to complain 2 years after his surgery. And maybe he had some subacute endocarditis. We don't know, in fact. But he started to complain, and his symptoms were really progressive. And even with a maximum medical treatment, this is a Hani Sabur patient, by the way. So even with the maximum medical treatment, he couldn't control his heart failure. And the patient kept coming and complaining of the same symptoms with severe dyspnea on exertion. He's a very active man. He's a CEO of one of the junk food industry, very important person. And he was really suffering about his residual mitral regurgitation. And he had secondary pulmonary hypertension and tricuspid regurgitation also. So this added to his problems, and he needed to do something about his condition.
And a tear procedure, edge-to-edge repair, like a mitral clip, in this instance, I think it would be very challenging because he had a failed repair, right?
No,
so it's
way,
not possible.
No way, because you don't have an edge
it's
of
friable
the
edges
leaflet.
also.
You don't have a posterior leaflet
to clip it.
If you see the echo, the posterior leaflet was really very restricted,
rudimentary,
and, immobile, and you cannot put your clip. You have only a single leaflet scenario here.
Okay.
It is only the anterior after the first repair. It is only the anterior leaflet moving, and you cannot put a clip. Yes. So the safest, even a trial of doing another repair, I believe it would not be successful for this patient. So we choose to replace his valve, and we choose a biological valve, so he will not need anticoagulation for a long time. He's 63. I believe that a biological valve will give him a headache-less scenario for the next 15 years, 20 years.
Thank you, Dr. Walid, for your excellent cases presentation. And my question is regarding the second case of annuloplasty for mitral prolapse. Yes. The question is, what is the actual guidelines nowadays for medical treatment post-operative after annuloplasty for anticoagulation, antiplatelets, for how long?
A very good question. So this patient needs to be anticoagulated on warfarin for 3 months. And the reason is we are using an artificial ring for the annuloplasty. This ring becomes completely industrialized and covered by human tissue within 3 months. So warfarin target INR 2 to 2.5 only, and after 3 months he doesn't need any kind of medication, and this is what happened to this patient. So he stopped, he was on beta blocker, and he was on diuretics, and he was on warfarin. All his medication stopped right now.
And what about the post-operative medical treatment, again, for anticoagulation after the biologic valve, and for how long?
The same applies. 3 months of warfarin. These are the guidelines and my personal preferences also, and give safety to the patient. Some surgeons are keeping their patient on 6 months warfarin. I think it is not required, because after 3 months, there is a full coverage of the strut and the stent of the valve by human tissue. So no need for more anticoagulation. Please, Dr.
Thank you, Dr. Walid, for always nice cases. And in my experience with you, you know that how many patients, alhamdulillah, I succeed in treatment because of you. My question from cardiologist, not surgeon, for tricuspid repair, annuloplasty, are you using ring or not? And if you are using, when you are using ring and when you are not using ring in tricuspid?
It's a very good question. All the good results are due to the good diagnosis and good treatment and good decisions, because it's really a hard team. Without the hard team, without this hard team, we cannot achieve these results. It's a diagnosis and management optimization of the patient case, so we are all working in the same way and direction. The tricuspid repair, what I'm doing, if the patient doesn't have pulmonary hypertension, I can do a tricuspid repair only without ring. For example, a patient with mitral stenosis and secondary or tricuspid regurgitation without high pulmonary pressure, I can use a De Vega repair without ring. But with patient with elevated pulmonary pressure, I prefer always to put the ring, because we know as per guidelines that the ring is a sustainable way to do the tricuspid repair, especially facing a high pulmonary pressure. If you do only a De Vega repair without ring against the high pulmonary pressure, this repair will fail within the next few years. So the ring is giving you consolidation of your repair, and it is advisable in all cases. Thank you.
Thank you, Dr. Walid. So just I didn't hear the question. Is it with the question? So maybe I would ask the question again. So actually two questions. First, when you do mitral valve surgery with a repair or replacement, do you routinely treat the tricuspid ring in the tricuspid valve, regardless of the severity of the tricuspid regurgitation?
No, only if indicated, of course. I mean, mild to moderate tricuspid regurgitation, we are not treating.
But if it is trivial to mild, you would not.
You don't do anything, because only by treating the mitral
that should
problem,
reduce
this will improve the tricuspid by default, as you know.
Yeah, but if there is moderate, you would put.
More than moderate, I always do a tricuspid repair without ring. If the blood pressure...
Repair by what? By ring or repair by...
Without ring. If
without
the pulmonary pressure is low. If high pulmonary pressure, I put a ring.
You put a ring. That's what. Now, second question. When you consent patient for mitral valve repair, suitable for repair, so they have prolapse or they have degeneration of the valve, you think suitable for repair. So what would you give them the percentage of transferring to mitral valve replacement in your practice?
So we have to explain to the patient.
But what is the risk roughly? Because that's an important question. You know, is the big difference between repair and replacement in terms of the patient's perspective and need for warfarin and so on.
As you know, we prefer to go for repair. Yani personally, I didn't do a mitral valve replacement for regurgitation long time back.
So your success rate?
I prefer to go for a repair and always try to do the repair, and I test my repair intraoperative by TE, and I re-repair if I need to do. So the valve conversion to valve replacement is very rare nowadays.
5%?
If you are maybe 5% if you plan for a mitral repair from the beginning. But of course, when you consent the patient, you have to give them the possibility.
Which is 5% or 10%,
something like that. And you have to explain to the patient the types of valve we may use, and he has to choose the valve. If we fail to do the repair, he has to choose his valve, prosthetic, mechanical, or biological. So this is always what we're doing, but the conversion rate is very, very rare for a mitral.
Thank you, that's fine. Thank you. Thank you.